Sydney Cancer Genetics explains fertility and breast cancer. Hi, I'm Dr. Hilda High, a genetic oncologist. I see patients in rooms at the Sydney Adventist Hospital in Wahroonga, Sydney, and I do telehealth consults throughout Australia to GP practices and even patients' homes. This presentation on fertility and chemotherapy has been put together as part of a presentation given to women with a BRCA1 and BRCA2 mutation, but it's relevant for many women. This is because 20% of women develop breast cancer while premenopausal. That is, about 6 to 7% of women will be less than 40 and about 10% between the ages of 35 and 45 at the time they're diagnosed with breast cancer. Using 2 case studies, I'll discuss the issue surrounding having a baby after breast cancer, whether it's harmful, whether it's possible, and whether breastfeeding is possible as well. I will also discuss the damage done to the ovaries. And lastly, for those not wanting to have a baby or those on tamoxifen, we'll discuss contraception. Scenario 1 is a 37-year-old woman whose breast cancer was diagnosed 5 years ago at age 32. She underwent a mastectomy and had chemotherapy and has completed 5 years of tamoxifen. She now wants to have a baby. She has a couple of questions. First of all, she wants to know, is it going to be harmful to be pregnant? Will it increase her risk of the cancer coming back? And will it increase the chance that her baby will have birth defects? She also wants to know whether the chemotherapy has affected her ability to conceive, and, having had a mastectomy, whether she can breastfeed. Let's start with the question about whether it's harmful. There have been quite a few studies now done, and they've shown no effect on the cancer coming back, what's called a recurrence, particularly if no nodes were involved at the time. In those studies following full-term pregnancies, it seemed to actually show that the women did better. Importantly, for this woman, there is no increased risk of birth defects. It's the same as the general population, 2 to 3% per live birth. However, there is a slightly increased risk of miscarriage, about 24% versus 18%, regardless of the treatment received. It's not exactly sure why this is. As most women are aware, the biggest effect on fertility is a woman's age, as this graph shows. A woman is most fertile in her early 20s, and this starts to decline quite dramatically in her early 30s and tapers off in her 40s. This is related to the number of follicles. These are the cells that make the eggs. Interestingly, a woman is born with more follicles than she will ever have again, about 1 to 2 million. By puberty, these have declined. The medical term is atresia, to about 300,000. When a woman reaches 400 eggs, that's when the menopause occurs. The effect of chemotherapy is to cause a sharp drop in the number of follicles, and then, as the woman ages, the rate towards menopause continues as normal. However, because of the drop, menopause will occur at an earlier age. This is a very good resource and one that I highly recommend. Fertile Hope has a risk calculator for men and for women based on the type of cancer and the type of treatment. In terms of chemotherapy's effect on fertility, cyclophosphamide, used in the old CMF regimen, has the highest effect on fertility. A moderate risk is seen by more of our modern chemotherapies, including cisplatin, doxorubicin, and the taxanes. So is breastfeeding possible for a woman that has had a mastectomy or has had radiotherapy? In those studies that have looked at it, breastfeeding has been possible in about 30% of the women who wanted to try. Importantly, the milk is nutritionally adequate and there is no increased risk of breast cancer. In scenario 2, we have a 36-year-old woman who's just been diagnosed with breast cancer following the identification of a lump in her breast. She's been advised that she should have chemotherapy followed by tamoxifen, and because of her family history, she's planning to discuss genetic testing in this time period, as it may influence her choice whether to have radiotherapy or a completion or even bilateral mastectomy. However, she wants a baby. So her question is, can infertility be prevented either before or during the chemotherapy? Are the treatments harmful? And when would it be safe to try for a baby? Again, Fertile Hope has a very good resource with their options calculator. Unfortunately, chemotherapy does damage the ovaries, and it does this either by damaging the developing follicles, the ones that develop each month, and you can see them here as they move from the developing primary follicle through the secondary and eventually to this mature cell which will release the egg. But we also know that the primordial follicles, the ones that are waiting to go through this cycle, can also be damaged. And ovarian tissue, or the stroma, where some of these important hormones come from to drive this cycle, may be damaged as well by chemotherapy. Unfortunately, the studies to date trying to protect the ovary have not been successful. The other issue is, are the treatments used to protect fertility harmful in themselves? In the case of IVF, hormonal stimulation is used to make sure that more eggs are released than would normally be done in a single cycle. The exact effect of this on cancer is unknown, but it appears to be very small. Aromatase inhibition, the same sorts of medications that are used to treat breast cancer, can be used to ensure that the estrogen level in the blood stays as low as possible. However, fertility treatments have other problems. They can increase the risk of blood clots in the legs, and this can be added to the risk that's associated with some cancers. Perhaps also importantly, there is a time frame in which fertility treatments need to be done, and this can delay the treatment of the cancer, and fertility treatments are expensive. So in terms of preserving fertility, what are these women's options? Well, the first, perhaps most obvious thing is to remove and store the ovarian tissue. This has the advantage of not needing any stimulation. However, the ovary is a very complicated organ, and from worldwide studies, only 2 babies have been born from this so far. It is an area of ongoing research, though. Much more commonly, a cycle of IVF will be done with stimulation to release as many eggs as possible. This is called mature oocyte cryostorage with vitrification. Those eggs are then frozen to be used at a later time. It's not as good as embryo storage, but it is improving, and over 180 babies have been born worldwide using these techniques. The most common and well known is the embryo freezing. However, this requires sperm, either from a partner or from a donor, and that can be difficult to organize at short notice. There are also ethical issues for some people, that this involves storing an embryo and not just tissue. The success rates are good, and it's the most common and most successful of our fertility treatments. The most important thing is to ask to speak with a fertility specialist very early on, the moment the cancer is diagnosed. Even if you decide not to go ahead with it, it's important to have these discussions. So when is it safe to try for a baby? The cytotoxic effects, that is, the baby harming effects of chemotherapy, will be gone within 6 months. So 6 months after the last chemotherapy is the recommended time. However, some doctors suggest waiting 2 years. This is in part to make sure that the cancer really is gone and not coming back. Some doctors would suggest that if the cancer was high risk, that is, a large cancer or multiple lymph nodes involved, that a woman should wait 5 years. There's no good evidence for this, and I would discuss it with your doctors. However, it's very important to note that tamoxifen is teratogenic, that is, it's damaging to the growing baby. It's very important to use effective, non-hormonal birth control while taking tamoxifen. Not everybody wants a baby, or maybe not just now. So what sort of contraception is recommended? Contraception tends to fall into 2 categories, hormonal and non-hormonal. Hormonal forms of contraceptives are the most effective if they're tolerated and taken regularly. Perhaps the best known is the combined oral contraceptive pill. Non-hormonal contraception, including the intrauterine device, which importantly is much safer now than those early IUDs that were used, or barrier methods such as the diaphragm or condoms, and condoms of course have the extra benefit of protecting against sexually transmitted illnesses, and of course permanent methods such as tubal ligation in a woman and vasectomy in a man. What are the risks of using hormonal contraceptives? Well, the risks of hormonal contraceptives are there for all women, and they include blood clots and stroke. This is often a bigger risk than that of a cancer. It's important that your doctor should check your blood pressure, your family history, and you mustn't smoke while taking hormonal contraceptives, as this increases these risks. Large studies have shown that there is a small increased risk of breast cancer, although more recent studies have shown that it's not significant. This occurs mainly while a woman is taking it, and the risk goes back to baseline after about 10 years. Even for a woman with a history of a BRCA1 or BRCA2 mutation, hormonal contraceptives are regarded as safe. They also have a small decrease in the risk of ovarian and uterine cancer, and this decrease in risk continues after stopping. Again, more recent studies have shown that this is true for the BRCA1 and BRCA2 mutation carriers. For more information, see our Facebook page and the post on this. So in summary, pregnancy after breast cancer is not harmful. It is possible, but it will depend on the age of the woman, the type of chemotherapy she had, and her family history of menopause. Breastfeeding is possible, safe and nutritious if a woman wants to pursue it. Unfortunately, we can't prevent the infertility that can be caused by some of the chemotherapies. However, there are fertility treatments, such as IVF, that allow the storage of oocytes and embryos to allow a baby at a later time. When is it safe to have a baby? That depends on the individual and the cancer that they had, and this should be discussed with the doctor and the person's preferences in mind. However, from the studies that we have, it's unlikely that an early pregnancy will cause a recurrence. Hormonal contraception is fine. It has no significant increase in breast cancer risk and can be used even by those at very high risk of breast cancer. Importantly though, hormonal contraception can't be used with tamoxifen. More information is available on the Sydney Cancer Genetics website and our Facebook page. Thank you.